Hello, my name is Dr. Ravi Bharadwaj and I am from Apollo Hospitals, Kolkata. Today, I will be giving you a brief overview of distal radius fractures. The highlights of this presentation is an overview of distal radius fractures and to briefly touch on the classification systems and the principles of treatment. The learning objectives of this talk are to recognize the types and the classification basis of distal radius fractures, to evaluate the X-rays to assess stability, to understand the principles of the various treatment modalities, and to apply the principles to develop a suitable treatment plan. Now you have to realize that distal radius fractures are quite heterogeneous and represent a broad spectrum of injuries which can range from very simple fractures all the way to complex fracture dislocations. The demographics of distal radius fractures, they are very common and account for about 17.5% of all fractures in adults. They are more common in female, almost twice as common, and they characteristically show two peaks and follow a bimodal distribution. In young patients, the mechanism is a high energy trauma like a RTA or a fall from height. And there is a second peak in the elderly population associated with a low energy ground level fall, consequence of osteoporosis. If you look at the distal radius anatomy, the distal radius transmits about 80% of the axial load. It articulates with the scaphoid, the lunate, and the distal ulna through the scaphoid fossa, the lunate fossa, and the sigmoid notch of the distal radius, which articulates with the head of the ulna. The distal radius and the wrist can be thought of comprising of three columns. The radium column stabilizes the carpus, the intermediate column transmits the load, and the ulnar column is responsible for DRUJ stability and forearm motion. If you consider the mechanism of injury, most of these injuries are as a result of a fall on outstretched hand. And the deformity is determined by the position of the wrist at the time of impact. So for example, in Colles fracture, there is a dorsal angulation because the direction of the force is directed backwards. And because the Smith fracture is caused by a fall on the back of the hand impact, the deformity is volarwards and the distal fragment is angulated anteriorly or volarwards. Up to 50% of these fractures are intra-articular fractures. There may be many associated injuries which should be carefully looked for. They can be in the form of scaphoid fractures, scapholunate ligament injuries, or TFCC tears, which may require an MRI for diagnosis. There may be associated median nerve injury if there is significant angulation of the fracture and the median nerve is tented over the proximal fragment. Let us consider some historical aspects and some eponymous fractures. Abraham Colles was an Irish surgeon who gave his classical clinical description of distal radius fractures. He lived between 1773 and 1843. He was followed by Smith, who was his successor, and Smith gave his description of a reverse Colles fracture. Incidentally, the French term for a Smith fracture is a Guérin fracture, named after Jean Guérin, who described this fracture even before Smith gave his description. John Barton was a US surgeon who gave his description of the intra-articular fracture which bears his name. And Hutchison gave us the description of a Schoffer's fracture, which we shall deal with in a moment. A Colles fracture is typically an extra-articular fracture occurring in the elderly and in osteoporotic bone. It presents with a dinner fork deformity. You can see the typical dinner fork deformity here. And if you consider the X-ray, the radiology, these are the deformities. There is a dorsal displacement and a dorsal tilt. There is a radial displacement and a radial tilt, and there is impaction and supination of the fragment. So these deformities comprise the elements of a Colles fracture. Treatment is usually by manipulation under anesthesia and application of a Colles cast. The reduction maneuver involves traction and counter traction, disimpaction of the fragments, correction of the deformity, and application of a well-molded Colles cast. To talk about the cast, proximally it should hold the mobile ward of Henry. It is a below elbow cast and it is angulated slightly towards the ulnar side distally so as to not to interfere with elbow flexion. And the distal extent of the cast is to leave the base of the thumb free and extend up to the proximal palmar crease here and up to the knuckles so that it is able to completely bend the fingers and make a tight fist. The Smith or the Goyrand fracture is a reverse Colles fracture. It is also an extra-articular fracture as a result of low energy caused by impact to the back of the hand, and it presents with volar displacement and tilt. This is treated in an above elbow cast to neutralize the deforming forces, and this is the reduction maneuver, and this is the plaster. It is an above elbow cast with the forearm in supination with the elbow flexed to 90 degrees, and the rest is kept in a dorsiflex position, the so-called beggar's position. Barton's fracture are high energy intra-articular fracture. Actually, they are fracture dislocations because there is an associated subluxation of the carpus along with the fracture fragment, either volarly or dorsally. If it involves the volar lip, it is called a volar Barton fracture. If it involves the dorsal lip, it is called a dorsal Barton fracture. These are shear injuries and ideally they should be treated by buttress plate fixation. Hutchison gave his description of a Schoffer fracture. These are also called backfire fracture. The name comes from early cars which required a hand crank start. The backfire caused the crank handle to hit the palm, causing this typical fracture as you can see in this picture here. Basically, these are radial styloid fractures which are intra-articular. The size of the fragment may vary and these require accurate reduction and fixation. Let's talk about the normal anatomy and the X-ray evaluation of the distal radius. Normally, PA views and lateral views are requested. Sometimes oblique views may also form a part of the workup. The average palmar tilt in a distal radius approximates about 11 degrees. This is seen on the lateral view. The radial height averages about 10 millimeters. This is seen on the PA view. And the radial inclination averages about 23 degrees. And this is also seen on the PA view. The ulnar variance is usually neutral. It can be plus or minus 2 millimeters and accounting for either a positive or a negative ulnar variance. And always comparison should be made with the intact side. When we are dealing with the distal radius fracture, we have to aim to restore the radiological parameters to as normal as possible. Sometimes traction view is very helpful. You can see this fracture where it is difficult to see the alignment and the displacement of the fragments, but a traction view with adequate analgesia or just before surgery after anesthesia has been given is very useful. It tells you how much of reduction is possible, and also you have a better delineation of the different fracture fragments as you can see here. So this is a very useful treatment modality, particularly when CT scans are not available. CT scans form a very useful tool in the workup of these fractures, especially for intra-articular fractures for planning the surgery. It offers excellent visualization of the sigmoid notch here and for detecting depressed die punch fractures, intra-articular fragments, and also when the fragments are very comminuted. MRI scan is not routinely used in distal radius fracture. It occasionally has a role when you are suspecting a scapholunate ligament injury in association with the fracture and associated TFCC tears. An ideal classification system of the distal radius should be relevant and reproducible. It should be able to predict the prognosis and guide the treatment. It should be validated, and it should be simple to use and understand. Unfortunately, over the years, no one system has been able to fulfill all the criteria. With the result, there is a myriad of fracture classifications available. So over the years, more than 15 different classification systems have been in vogue from 1951 to present day, but we will talk about only some of the common ones. The Frickman classification, easy to remember and described by Frickman in 1967. Basically, it comprises of 8 types. The 1, 3, 5, and 7 odd number types represent an extra-articular fracture, an involvement of the radiocarpal joint, an involvement of the radio-ulnar joint, and a combination of the radiocarpal and the radio-ulnar joint. And the odd number fractures 2, 4, 6, and 8 represent an added styloid fracture in combination with the corresponding variant odd number. So, for example, type 2 is a type 1 with an ulnar styloid, type 4 is a type 3 with an ulnar styloid, and so on and so forth. Malone in 1984 gave a different classification. He described 4 different fragments, which were basically the proximal shaft fragment, the styloid fragment, and the intermediate column was divided into a dorsal and a volar fragment, so comprising of 4 fragments in total. And based on the involvement of these 4 fragments, he came up with a classification of 5 subtypes. In type 1, there is no communication and only minimal or no displacement of the medial complex. Type 2 represents the dipudge injuries, which are subdivided into type 2A and B, depending upon whether there is moderate medial complex displacement or there is added comminution of the dorsal and volar cortices. Type 3 represents a type 2 fracture plus a spike of the radius volarly. Type 4 represents a split fracture with severe comminution and rotation of the fragments. And type 5 represents explosion injuries with severe comminution. Later on, in 1990, Muller gave us the AOASIF classification. And this is a very useful alphanumeric classification. And although it does appear a little bit cumbersome at present, it is a very detailed classification and quite easy to master once you've got the hang of it. Basically, it comprises of alphanumeric classification. So 2 represents the forearm and 3 represents the distal end of the forearm. So any distal radius fracture in the AO classification would classify as a 2-3 fracture. And then depending upon whether it is extra-articular, which would classify it as type A partial articular fracture as a type B, and a complete articular fracture as a type C, you could divide it into 2, 3 type A, B, and C fractures. Now there is a subdivision of each component. Type A is divided into A1, A2, and A3. Type B represents the partial articular, the shear fracture, the Barton fracture, so to speak of, and this represents the type B fractures, and these can be subdivided into B1 involving the styloid, B2 involving the dorsal lip of the distal radius, and B3, the palmar, the reverse B, that is the B3, which is representing the polar Barton fractures. And type C represents a complete articular fracture, which subdivided into C1, C2, and C3, depending upon the level of comminution. Fernandez gave us a classification in 1993, which correlates not only the mechanism of injury, whether it is bending or a shear or an avulsion, etc., and also describes the fracture fragment and also suggests the most appropriate treatment modalities. So this is also quite a useful classification if you want to use it. The 3-column concept is very important to appreciate when you're dealing with distal radius fractures. And this was given by Rickley and Regazzoni in 1996. Basically, it talks about 3 columns of the distal radius, each with a different role. The radial column gives stability because of attachment of the various ligaments and resists translation forces. Intermediate column comprises the lunate fossa of the distal radius and transmits most of the compressive load. And the ulnar column comprises of the TFCC and is responsible for DRUJ stability along with the ligaments. There is another concept which has come into vogue with the frequent use of CT scan for complex fractures, and that is the key corner concept. The 4-corner concept talks about 4 different corners in the distal radius, basically the styloid fragment, The intermediate column divided into a dorsal and a volar component and the ulnar component. So each corner has a separate function, each behaves differently, and these corners can be involved either individually or in paired combinations to give you various permutation and combination of fracture patterns. This was given by Brick and Rickley in 2016. The concept of the key corner is given by the direction of the displacement of the lunate on the intermediate column sagittal cut CT. So if you take a sagittal CT of the intermediate column, you see whether the lunate is subluxed, dorsal, or volar. Let us take an example. You see this example here. This is dorsal, this is volar. This is the intermediate cut. You can see that there is a fracture here. There is also some comminution here, but the lunate has displaced on towards the volar side. So the key corner here is this fragment here. So this needs to be identified and buttressed. On the other hand, if you take this fracture, this also has comminution both volarly and dorsally, but you see the lunate has displaced dorsally. So the key corner here is this dorsal fragment, and this needs to be buttressed. So the key corner needs to be determined and fixed for each intra-articular fracture involving the intermediate column. And they may not necessarily be the largest fragment. It has to be appreciated. Most of the time, it is very important to appreciate patient factors, the fracture pattern, the fracture stability, and also take into account the associated injuries. The most important questions to ask are whether the fracture is displaced or undisplaced, whether there is an intra-articular or an extra-articular component to the fracture, whether the fracture is reducible or irreducible, and after reduction, is it going to be stable or unstable? To predict the instability factors, of a distal radius fracture, Lafontaine gave his criteria in July 1989, which was published in the Injury Journal. So the factors which were likely to cause instability in a fracture are advanced age and osteoporosis. If there is comminution of the dorsal cortex involving more than 50% of the diameter of the bone, if there is palmar metaphyseal comminution, if there is intra-articular comminution, if the initial displacement is significant as per these parameters, if there is an associated distal ulnar fracture, then it is going to be unstable. And if the fracture displaces after close treatment, then obviously it is unstable. So if you have predicted according to Lafontaine's criteria that the fracture is likely to be unstable, then it may be preferable not to go for a fracture treatment modality like a plaster, but instead go for a more robust internal fixation as a treatment plan. Which brings us to the next question. What is an acceptable reduction? If we achieve less than 15 degrees of dorsal or less than 20 degrees of palmar tilt with greater than 15 degrees of radial inclination, less than 5 millimeters of radial shortening, ulnar variance should be either negative or neutral, and the articular gap or step should be less than 1 millimeter. If we can manage to achieve these radiological parameters, then the outcome of distal radius fracture should be satisfactory. Treatment modalities are plenty and sometimes very confusing. The commonly accepted treatment modalities are manipulation under anesthesia and plaster of Paris cast, K-wire fixation, external fixation, or a combination of K-wires and external fixation, a volar plate fixation, a fragment-specific fixation, or in certain cases, an arthroscopy-assisted fixation. Before starting, as a judge, you should be very impartial and should take these following parameters into account. Speak to the patient. Understand the patient's functional demand. Consider the bone quality. Decide on whether any additional imaging like CT scanner, etc. is required. Do a resource check. Do you have all the resources required to treat that particular fracture? For example, a complete inventory of plates, etc. Do the finances justify the treatment method that you are planning to use? Do you have the required skill set to carry out the treatment plan that you have chosen? So before we start, it is also important to bear in mind the American Academy recommendations, which states that no particular method of fixation can be recommended over another. And actually, there is no level 1 clinical evidence suggesting a superior treatment modality for the treatment of distal radius fractures. So there are still a few unanswered questions. But the chosen indications for each treatment modality are as follows. If you are considering manipulation under anesthesia and a POP cast, these are for minimally or slightly moderately displaced fractures. The fracture should be reducible and it should be stable once reduced in a plaster. And even if you have applied a cast according to the technique which has been discussed in the earlier slides, it is very important to follow up with serial weekly X-rays for 3 consecutive weeks to make sure that there is no secondary displacement after the swelling has subsided and the fracture doesn't displace further in the cast. K-wires. They are usually indicated in unstable extra-articular fractures and in certain intra-articular fractures where there is no significant comminution. For example, a radial styloid fracture or a simple intra-articular fracture. They can be used in young patients where there is no osteoporosis, so the chances of collapse are lesser. But they are contraindicated in the following scenarios. Do not use them in a volar Barton fracture. This is a shear fracture which should be treated with a buttress implant. K-wires will not reduce a joint depression fracture. Or if there is an articular step off of greater than 2 millimeter or severe initial displacement, or there is severe osteoporosis, perhaps a different treatment modality like an internal fixation would be more appropriate. Also, when there is an associated ulnar fracture, simple K-wires probably will not be stable enough to give you the stability to maintain the reduction like you want. This is an example of an extra-articular fracture which has been treated by K-wires. There are multiple different K-wire configurations. Most commonly, usually there is 1 or 2 radial K-wires, and then there is one applied from the dorsal aspect on the intermediate column, which may be directed so in a crisscross formation. There are multiple K-wire configuration available, and it is a personal preference and based on individual experience. This is an example of a simple articular fracture which has again been treated by K-wire fixation, cross K-wires. Now, this gentleman, Adalbert Ibrahim Kapanji, is a French orthopedic surgeon of Greco-Turkish origin, and he gave us his method of intrafocal pinning, which is a very useful way to use K-wires. Basically, what it involves is manually inserting the K-wire percutaneously into the fracture site by hand, and then levering the K-wire and using it to reduce the fracture fragment, and before driving it to engage the opposite cortex with a drill. So by using this technique of intrafocal pinning, it is possible to not only reduce but also maintain the reduction. He described this technique for use in extra-articular fractures in 1976 and followed it up with another paper for intra-articular fractures in 1987. Now, K-wires are not without their own complications. We have to be careful when using them. Pin track infection is very common if you are not careful about sepsis, about sterility. You could impale nerves and tendons if you are not careful. So the advocated technique is a mini open nick and spread, where a small nick is made in the skin and a blunt hemostat is used to remove the nerves and tendons from the path of the intended K-wire, so that you can keep the hemostat against the bone before you drive your K-wire. So this is a mini open technique, and you can see how close the superficial radial nerve is to the K-wires that you have passed. So it is very easily possible to cause iatrogenic damage. The external fixator is a very versatile tool in the orthopedic surgeon's armamentarium. It is indicated in selected comminuted or open fractures of the distal radius, and the basic two designs are the bridging and the non-bridging design. The bridging design spans the wrist and the non-bridging does not, as you can see here. Bridging X-fix employs the principles of ligamentotaxis to reduce and maintain the reduction. The non-bridging X-fix is useful only when there are extra-articular unstable fractures with large distal fragment, so you don't need to cross the joint. So non-bridging X-fix has been popularized by Margaret McQueen from Edinburgh. The pros of external fixation: they are minimally invasive. Reduction is achieved by distraction and ligamentotaxis. And the cons are: joint often cannot be reconstructed, an intra-articular die-punch fracture cannot be reduced, and it is difficult to initiate early motion. External fixator, therefore, is reserved for severely comminuted fractures or open fractures, and they can be used in addition to K-wire fixation to supplement the fixation of K-wires. This is an example of a severely comminuted fracture. You can see an external fixator has been applied. And although it's not a perfect looking X-ray, the functional result is rather good in this elderly lady. External fixator also have the same type of complications as K-wire. In addition, you can cause over-distraction and stiffness of the fingers. You can cause cutaneous nerve injury by the pins, and again, pin track infection similar to that seen with K-wires. Sometimes a hybrid fixation employing K-wires and X-fix can also be very useful. When you consider open reduction and plating for distal radius fractures, the goals of treatment are as follows. You want to achieve an anatomical reduction of the joint. You want to have sufficient stability to allow early range of movement. The volar approach is therefore most commonly used, and it is also used when there is some dorsal comminution, because it is a stable fixation which allows us, with the current generation of plate, even to get away in cases where there is dorsal comminution. Implant of choice is usually a volar locking plate. So volar locking plate typically used in unstable fracture scenarios, for example, in volar Barton fractures, something like this, when there is significant comminution and when there is an intra-articular step. Also in high functional demand patients like athletes and sports persons. Fixed angle locking plates. These are the initial generation of locking plates which had fixed angle screws, in which the screws were inserted in a pre-designated direction only. Biomechanically, these represented very stable fixation, and both dorsal and volar locking plates are available. An improvement on that is the variable angle plates and screws, in which the surgeon has control over the screw trajectory, which can be varied in a 1 to 15 degree cone in any direction. So this is a huge advantage for the surgeon, especially in dealing with periarticular fractures with multiple fragments like this. So the surgeon can use this feature to direct the screw trajectory to engage the central part of each comminuted fracture fragment to give maximum purchase. So it's a huge advantage. The concept of the watershed line is very important in distal radius fractures. The watershed line represents an imaginary line which is just distal to the attachment of the pronator quadratus. So on the lateral aspect of the distal radius, it represents a ridge, but on the medial side, it is not so distinct. It follows a line which is in between the distal most prominence on the medial side and the attachment of the pronator quadratus. So it is the wavy imaginary line here. The importance of the watershed line is that any implant which is placed on the distal radius is less likely to cause tendon impingement problems if it is placed proximal to the watershed line. And any implant which is at the level of the watershed line or beyond is likely to cause tendon impingement problems. So unfortunately, there is a subset of fractures which are volar articular rim fractures, which are very distal, and they also involve the joint. So here you have no choice but to cross the watershed line with the chosen implant, which is often a rim plate of this design. So here the plate extends beyond the watershed line, as you can see, And although these plates have a greater tendency to cause flexor tendon irritation, they should ideally be removed once the fracture union has happened within a few months. The normally employed approach is a modified Henry approach or a volar approach, which goes between the artery and the FCR tendon. You split the sheath and then split the forearm fascia and retract all the tendons to the ulnar side, and that will give you access to the pronator quadratus muscle, which is erased off the distal radius in a step cut L fashion, which gives us access to the entire distal radius volar surface here. So this is an example of a volar Barton fracture which has been fixed with the volar locking plate. The complications of volar locking plates is mainly related to the metalwork and the screws. It can cause tendon irritation and rupture if you're not careful, and there is a chance of iatrogenic intra-articular penetration of the screws if the screw length and the trajectory is not accurate. Tendon irritation with volar plates, here you can see it is more common with thicker plates and less with low-profile thinner plates. Bicortical locking screws should be avoided because they may pierce the dorsal cortex and cause attrition of the tendons, as you can see in this picture. Now, Soong gave us a very useful classification which corroborates the distal extent of the plate placement and the possibility of FPL irritation. So you can see with the plate being so distal and the FPL tendon coursing like this, the FPL tendon can be tented if the plate placement is very distal. So Soong gave us a quantification of this, and his classification is based on the position of the plate with respect to a critical line. This red line here is an imaginary line which is drawn on the most volar bony prominence of the distal radius and parallel to the long axis of the radius. So this is the critical line here. So grade 0 is when the implant is dorsal to the critical line and it is proximal to the joint line here. So these plates will rarely cause any tendon problems. Grade 1 represents a plate position which is at the level of the critical line but still proximal to the joint, and grade 2 where the plate actually crosses the critical line and comes more volarwards, and also distally it extends to the level of the joint and beyond. So that is a grade 2 Soong, and that plate placement is most likely to cause flexor tendon impingement problems. And if any plate placement is placed in such a way that it extends beyond the watershed line, then care should be taken to follow up this patient and remove the plate early at the very early sign of tendon impingement. There is also the need for a true lateral X-ray. We all know that the normal radial inclination is as follows. It's about 20-22 degrees. And if we take an X-ray post-fixation with the styloid screw in C2, we get an X-ray often like this on the C-arm, and that gives us the erroneous impression that the styloid screw has actually penetrated the joint. And this is because of the normal radial inclination. Now, to compensate that, what we need to do is lift the forearm about 20 degrees off the table to take out the radial inclination from the equation. And this is a true lateral X-ray. And now you can see that the same picture here, the screw is very much within the joint and there is no intra-articular screw penetration. So when you're taking a lateral X-ray, make sure you take a true lateral X-ray by lifting the forearm about 20 degrees off the table. The other important thing is to avoid penetration of the dorsal cortex with your locking screws. So the locking screws should stay well clear of the second cortex or the dorsal cortex when you're applying them from the volar side. Now, another thing to remember is the position of the Lister's tubercle here. So because of the prominence of the Lister tubercle, your screw from the volar side, especially the second or third screw, could still exit the bone on the dorsal aspect, but on a lateral view, it would give you the erroneous impression that it's intra-articular. So when you're choosing your screw lengths, it is important to maintain them adequate length and keep them short of the dorsal cortex. A carpal shoot-through view is very useful. Once your fixation is complete, you can take this C-arm picture, which actually gives you the outline of the dorsal cortex and the position of the screws with respect to the dorsal cortex. If your fixation is stable, you can go for this view, and this will tell you whether any of your screws has penetrated the dorsal cortex. Now, coming to fragment-specific fixation. In 1998, Medoff gave us the fragment-specific classification for intra-articular fractures, which is a very detailed classification describing various fragments such as the radial styloid fragment, the dorsal wall fragment, the dorsal ulnar corner, and the volar rim fragment, and the central intra-articular loose-free fragment. So based on this, they came up with the classification and also a system of implants which would be required to treat each of these fragments when dealing with these types of comminuted fractures. So the principles of fragment-specific fixation are the use of pin plates for styloid fragments, volar or dorsal marginal rim fractures. These are typically very, very low profile implants, and they rely more on the proximal fixation, and distally they offer a spring-like buttress effect, and still they are very stable enough to allow early mobilization. So let us take a few case examples. This is a dorsal and lateral plates applied using the fragment-specific fixation, especially in radial styloid fragment fracture like this, or a dorsal lunate facet fragment like this. You would need fracture-specific fixation. These are usually approached from the dorsal side, and this is a dorsal incision here. The extensor retinaculum is divided and the tendons are retracted to reveal the fracture, which is buttressed by these low-profile implants, as you can see here. And these are some post-operative X-rays of fragment-specific fixation, dorsal plating. Arthroscopic assisted fixation has been mentioned in literature, although it is not very common. There are only a very few centers which follow this routinely. It has some use in certain fracture patterns, and you can use dry arthroscopy to visualize the fragment and fix a large styloid fragment, for example, in this, and also allows us to see the intra-articular alignment and make adjustment by joysticking the fragment. So it is a useful tool, and it has some use, and some orthopedic surgeons prefer to use it routinely, but it is not very commonly used. And there is no long-term evidence to suggest that it adds appreciably to the final outcome. So in conclusion, when you're dealing with distal radius fractures, you've seen that there are various types and various patterns. So when you're dealing with them, you need to have a complete inventory of implants, which includes volar and dorsal plates, external fixators, K-wires, even suture anchors and headless compression screws, and maybe sometimes something like a compact handset, which uses small mini screws to tackle smaller fragments. In conclusion, classifications have their own place, but it is more important to understand the fracture mechanics and the personality of the fracture. It is important to appreciate the principles of treatment so that you can choose the most appropriate method for that individual patient. End of the day, you are committed to give the patient a good outcome. And while these classifications we have talked about and the treatment principles are very essential, especially when you have an exam to pass, when you are in clinical practice, it is very important to balance all these treatment modality knowledge that you have, so that you can formulate an individual treatment plan which is specific for that particular patient, taking into account the fracture personality. It is important to choose wisely because, as the adage goes, the evil that surgeons do lives after them, but the good is often buried with their bones. Thank you very much